Hello, everyone, and welcome to today's webinar. My name is Chris Marty, and I'm the Vice President of Data Analytics and Executive Education at MSCI. Before we get started, I'd like to go over a few housekeeping items so you'll know how to participate in today's event. You're looking at a screenshot of the Zoom attendee interface. You should see something that looks very much like this on your computer's desktop. You're listening using your computer's speaker system by default. If you'd prefer to join over a phone line, just use the Zoom audio settings interface and the dial-up numbers will be shown to you and you can dial in on your telephone. To minimize distractions and background noise during this webinar, your microphone will be muted for the entire webinar, and likewise your camera will be off also for the entire webinar. You'll have the opportunity to submit questions to our speakers by typing them into the questions pane in Zoom. You can send your questions in at any time during the presentation, and we actually encourage you to do that. We'll collect them all and address them during the Q&A session at the end of the presentation. I'd also like to let you know that there are some resources that we're going to send to you after the webinar today. We will send you copies of the handouts, the slides that are going to be presented. This webinar is being recorded and we'll make that available to you after as well. And there will be a link to additional material sent to you on top of all that. So stay tuned after the webinar. We'll get that material to you this afternoon. So with all that being said, I'd like now to introduce Steve Yates. Steve is the president of Optimum Safety. Optimum Safety is both a member and a partner of MSCI. Welcome, Steve.
Chris, thanks so much. I appreciate that. And we are excited to bring a great panel today to this discussion on our webinar around this COVID-19 topic. Lots of misinformation in the environment there, out in the media and so on, and we want to really bring a couple of experts that can slice through that and get you right to some great information. So today we have joining us Dr. John Koehler. John is a board-certified occupational medicine doctor, as you can see on the screen here. John's organization, Dr. Koehler's organization, OCDOC1, is developing a state-of-the-art work comp injury management guideline that helps medical providers serve their employer clients better by reducing lost time, unnecessary OSHA recordables, ER and specialist referrals, and overall helps control work comp costs. Employers can request that their providers check their cases against the OCDOC1 website each visit in order to capture these benefits. We would encourage you to check Dr. Koehler out at ocdoc1.com and see what he has to offer there. A lot of our clients and association organizations are utilizing his services. As well on the call today, we have Brian Dudgeon. Brian is a senior safety professional and account executive here at Optimum Safety Management. We're really pleased to have Brian on our staff. He handles many of our large and more complex clients, such as chemical processing and large fabricating facilities. Brian's got vast experience over many years in the safety arena that includes items even as extensive as explosives manufacturing. So Brian, welcome to the call today. We're really pleased to have you on our staff and with us today. I want to just tee up the webinar with some objectives. Really, our objective is to equip you with the necessary information to return employees to work as safely as possible. Lots of variables here, so we're going to talk through some of those today, and hopefully you'll leave the webinar with a lot more information and feel much more equipped to contribute to your organization in a way of returning the employees safely. The outline here, we will have an overview of COVID-19 by Dr. Koehler. And then Brian will walk us through the best practices for returning to work safely. I'll close us out with some next steps and also a discussion of some tools that are available. We are finding within our client base here at Optimum, but also within those that we're speaking to out in the general pattern of commerce that people are starving for some good tools. It's like a lot of information, but tell me what I need to do. And we've landed some of those tools for you, and we want to help get those into your hands. And then lastly, we're going to open up for Q&A. So we would encourage you to utilize the questions interface that Chris talked about earlier, and be ready with some good questions. You've got some great resources on the line to answer those. At this point, I'm going to turn it over to Dr. Koehler. Dr. Koehler, welcome to the webinar. We're looking forward to your comments.
Thanks much. Appreciate that. So I am a board certified specialist in occupational medicine. I've been on this issue since January. And so I'm going to provide an overview. First off, the COVID-19 is a virus. A virus is a rather diabolical type organism, so to speak. A bacteria, for example, has a fully contained ability to survive. In other words, it has all the organelles within it to function, reproduce, but a virus doesn't. A virus, in this case, is an RNA virus that must have a host cell to survive. It does not have the necessary machinery for independent survival. And so what it does, it actually attaches to a cell, injects its RNA into the cell, which then goes and co-opts the reproductive machinery of that cell, creating more and more viruses. So it's a really strange, how did this ever exist? Well, it does. So in this case, it's an RNA virus that co-opts the normal cell to reproduce the virus by taking over the machinery in the cell. So that's what it does. And then it is contagious because it's in the airway, and merely talking can disperse microscopic particles of fluid or moisture, so to speak, that carries the viral particles on it that go out at variable distances from the mouth of the person. So you can understand why coughing or sneezing is so bad, because it sends it out at such a high velocity that the reach distance is vastly greater with coughing and sneezing. But merely talking can do the same thing. And so I've seen the MIT study. If you want to go to chrismartinson.com or Chris Martinson on YouTube and watch some of his things, you could probably query the MIT study and see how conversation sends microscopic droplets out. So we'll talk about mass protection a little bit later. But the disease itself, it creates, once a person's infected, fever, shaking, chills, cough, sore throat, GI upset, which is kind of unique. Loss of taste and smell is also unique, along with the standard headaches and body aches. So I'm giving you the clue here that if someone has GI upset, loss of taste and smell, that those are bona fide symptoms of COVID-19 as opposed to the routine influenza. We are now outside of the influenza period as well, so that means more of these cases are likely to be COVID than they were before. The virus itself, they're learning still about what in the heck does this thing do to the body. It started out as a pneumonia because there were infiltrates in the lungs, and now it's not actually, it does create pneumonia because there's infiltrates in the lung, but doctors in America especially started saying, well, the infiltrates are bilateral and they always look the same. In standard pneumonias, that is pneumonias where you inhale the bacteria or virus by inhalation, causes asymmetric pneumonia. I mean, why would you have the same pneumonia on both sides in every case? 100% of the cases are bilateral and the infiltrates are the same. Why? Because it's a bloodborne disease. It's now believed to be bloodborne. That is, it distributes throughout the body and damages many organs through, there's thoughts about displacing iron from hemoglobin, which creates free iron, which is toxic, as well as preventing hemoglobin from binding oxygen normally, because it has to have iron to bind oxygen to deliver that to the tissues. What they do know is this creates hypoxia throughout the body. People come in with very, very low oxygen levels And it's believed it's because of this reason that the hemoglobin can't bind oxygen, so you have tissue hypoxia. Now they've also, I just read recently, autopsies showing blood clots in microvascular blood clots, which is also very bad in a sense that it would create decreased blood flow through the micro vessels, which are required in the lungs, for example, to exchange oxygen for CO2 over a membrane. Well, if you clog up the microscopic blood vessels, that can't happen. So that's a second mechanism to cause hypoxia, and a second mechanism to cause hypoxia in the lungs. But then also, if you can't deliver oxygen to the kidneys, liver, brain, heart, you're in trouble with that as well. The correlation, obviously, with diabetes is that diabetes already causes microvascular circulatory deficits. And so that obviously exacerbates, that's why diabetes is a risk factor, as well as heart disease. If you have narrowed coronary arteries and then you throw hypoxia into that mix, you have low blood flow to the cardiac muscle, that makes that even worse. The connection of that to obesity, I haven't read anything about that, but obesity is a big risk factor. It might be that the fat cells are starved for oxygen and they start breaking down and delivering into the bloodstream toxic products of a necrotic fat cell. So that's the latest on the pathophysiology of the disease. The state of the disease in terms of what's going on, we flattened the curve in the United States, thank God for that. The rate of increase of the deaths is flattening. They're increasing every day, but the percentage rate in which they're increasing has flattened, and we never did overwhelm our hospitals for ventilators. And now it's even thought that because of the new understandings of the pathophysiology of the disease, which I just enumerated for you, ventilators aren't critical because it's not a lung disease. It's a systemic hypoxia disease. So simply putting a tube into the lungs and puffing up the lungs doesn't help, because you can't force oxygen into hemoglobin where it can't bind it. It doesn't make any sense. You know what I mean? So high flow nasal cannula oxygen will max out your ability to carry it anyway. So you really don't need ventilators. So we made faulty assumptions early on that it was a pneumonia when it's not. It's a systemic hypoxia disease. The curve is flattened. The projections were way off, thinking millions of deaths. We're at currently today, this morning, 82,000 deaths and flattening. So that's very good news. Continuing to see good news relative to pediatric. There's only a few cases. There's a new inflammatory type of syndrome in pediatric patients with COVID, which is a new thing. It doesn't appear to be lethal, thank goodness. And the vast majority of everybody getting this disease, they get over it. I mean, they get over it like it's anywhere from, a nothingness, really. I didn't have any symptoms. I just tested positive, to people who say, yeah, I had a cold, or others that say I had fever for 5 days and I had rigors and shakes and chills and loss of taste and smell, and it was nasty, but I got over it. So literally 95% of everybody getting this gets over it forthwith, okay? The 5% ends up in the hospital, and 2% ends up potentially needing ICU, and a smaller percentage of that 2%. So overall, the mortality rate is very small. It's well under 1%. But nevertheless, with 330 million people in this country, that you have too many deaths, 82,000 so far by the Johns Hopkins Resource Center website, which you can look at too on a daily basis to see the numbers if you'd like. So there's still many, many questions that aren't answered, like, how do you get immune to it? Do antibodies really confer protection? We don't know that yet. I can tell you that having antibodies is good. It can never be bad. So that's good. So what protection actually affords, we don't know yet. We are nowhere near the term herd immunity as yet. There's big studies, big surveys going on now to find out just how many people have antibodies, because that would be the herd immunity concept. They say once you reach 80% of the population having antibody or some sort of protection, vaccination, then the virus can no longer replicate. It can no longer spread. It will die out. Remember, I said that it has to have a host, which means there has to always be virus in a human being in a population to keep it there. Get what I'm saying? So if the transmission rate falls below a certain level, all of those spreading tentacles, so to speak, of the disease die out. And when that goes away, the virus is gone, literally. So smallpox, for example, extremely deadly viral disease, was wiped out. It ended because they could no longer have a host. So that's going to be the same here. We don't know what mutations are going to take place. There, mutations is where in the replication of the virus, mistakes happen, so to speak. Anytime you have a machine or machinery, the replication can make a mistake. And so that can lead to either a fatal mutation, that is, the virus just dies off because it was fatal to the virus. It can't continue to work right, like a critical gear was omitted. Or it can make it even more diabolical by having a mutation that makes it even worse or sustains its ability, makes it more survivable in the human body or resistant to vaccine or antiviral agents or what have you. So anyway, we don't know. Vaccines, everything's on the fast track. You know, Restimivir, vaccination, hydroxychloroquine is out there too, zinc and hydroxychloroquine, because of its protection of the hemoglobin. And so we just don't know. As we open up our economies, there will be an increase in, obviously, viral infections, but there's so much social distancing and mask wearing now that we may not even have a large increase in cases related to returning back to work, because everyone is going to be so well protected. You go to the store now and they have these big plexiglass barriers. Everybody's wearing a mask. I mean, it's wonderful to see that, because we may be able to open our economy without much of an increase. So I hope we don't get hysterical in the media about that. Anyway, workplace safety issues. I want to make a comment immediately here about high-risk staff. As you go to open up your places of business, your factories, your warehouses, that high-risk staff absolutely has to be considered for protection. If you have folks diabetic, obese, hypertension, cardiac disease, high in age, older folks, that afford them the opportunity to opt out of returning to work without consequences. You'll need to be in consultation with your attorneys on that, but they need protected. If you force them to come back, you could have potentially a claim against you for doing that. So keep that in mind. Masks are a no-brainer for everybody to wear. Would you rather be bitten by a large rattlesnake or a small rattlesnake? I mean that by saying that I mentioned the viral particles being spread by conversation, coughing, sneezing. If there's a mask on, it creates a barrier, a physical barrier to anybody coughing, sneezing, or talking. In the reverse, coughing, sneezing, talking, when it hits that mask, it has to get through those fibers and bounces off the fibers, stick to the fibers, and you have a much less inoculation, or inoculum as it's called. That would be the initial dosage of the virus to your body, like a rattlesnake bite. What's the dosage you got, a big one or a small one? And it is directly correlated to severity of illness. So small inoculums mean smaller illness. That's critical. So you could drop your rate of having to be off work way down, or even your rate of cases way down. So even though somebody, unbeknownst to anybody, actually is in your facility with COVID-19, they may not spread it to anybody, and they may get over it without anybody knowing it and without anybody getting infected from it, because everyone's wearing a mask. Speaking to the issue of folks that may work in an area by themselves, driving a forklift down, 3 aisles that they always work in, no one else is there. For consistency's sake, I recommend that either everyone or no one. You have to be consistent with these HR policies. So consult with your attorneys if you want, but I suggest everybody wear a mask, because they have to go to the bathroom, go to the break room, walk through the hallway, go talk to HR, go talk to management. They need to have their mask on the whole time. it's just a no-brainer. I just don't know why anybody would not require masking. And if you need to procure the PPE, then I'm sure the folks on this call, Steve Yates, would be able to connect you up to folks that can get you the PPE you need. Being N95 is the best, but even surgical masks are better than nothing, or even a bandana is still better than nothing. So keep the distance, limit the meetings, no travel together, 0. Come on, nobody travels together with somebody else. That's just crazy. Sharing tools and desk space, spread them out. Plexiglass barriers for those, like, where there's a lot of conversations. For example, if there's a tool station where they have to go get tools or things from another person, you should have plexiglass up there. They can slide it under them, slide it around it, that kind of thing. Avoid contact. So physical barriers make sense. Risk mitigation and litigation control, same thing, that you need to take due diligence, you need to have a policy, you need to have it written up, you need to follow it. That way when someone makes a claim that they got COVID and are disabled because of COVID, because you caused it, you need to show that you put in place CDC recommended, which is what we're talking about, precautions and protections. Workers' comp, this is going to be dicey. Obviously, as the disease becomes more ubiquitous and is ubiquitous now in our societies, it's harder to attribute that to work unless there's a clear exposure. We were in a meeting, we had to be there. Joe was coughing, nobody had masks on. Joe ended up with COVID-19. Now 3 other people in that same meeting have it. You'll have a tough case defending that, because as it states that there has to be something peculiar to or increased by employment not common to the general public. So it's incumbent for workplace illnesses, which are OSHA recordable. Workplace illnesses are always recordable, that it's incumbent on the litigant to prove their case. That helps you because it has to be peculiar to or increased by employment and not common to the general public. So clearly this is common to the general public, but what this is in there for in the law is to protect you guys from the common cold. So people claiming got the common cold from work. Well, no, not quite. Okay. So, but early on, there were cases I know of where people coughed on people at work and they got COVID, others got COVID. So they're going to have some litigation to deal with. So keep that in mind. Testing issues, COVID-19 tests are available. Physicians Immediate Care, for example, I'm involved in that company. I'm the founder of it, actually, and still the medical director for occupational medicine. You can Google, visit physicians.com. You can find out how to get testing done if you're near one of our 37 Illinois clinics, 6 in Indiana. Then antibody testing is not quite available yet. There are issues related to the government allowing clinics to perform these antibody tests on a point of service basis, quick results. But right now, COVID-19 is available. If you meet the criteria, you have to set up an account with Physicians Immediate Care to get testing set up. And then antibody testing is not available just yet. There's companies exploring doing their own antibody testing, having a vendor come in to do it. That's a whole other subject. Testing for body temperature is something you can do, but again, it's requires logistics and planning and et cetera. Return to work issues are big, related to, do they have to have antibody proof to come back? I don't think that's advised, but lack of symptoms, certainly normal temperature. And with that, I will stop and turn this back over to Brian, and appreciate your time today. Take care.
Thank you so much, Dr. Koehler. So it's my pleasure today to talk a little bit about returning to work safely. I'll leave you just with one thought on this slide. What is a safe workplace? We all have some risk associated with everything we do. The only way we can offer a completely safe workplace is to close it down and don't offer any work. There's always some residual risk, so it's a relative term. Here's the topics we'll talk about today. Next slide. Infectious disease control program. What we're recommending to all our clients is take a two-document approach to this. Implement an infectious disease control program. It's a supplement. It's another document that goes in with the rest of your safety and health procedures in your safety and health manual. You've got lockout, you've got bloodborne, pathogen, confined space. This is just one more document that resides in that system. And what it does is it sits there all the time, and it directs behaviors around your organization, such as cleaning bathrooms, wiping break room surfaces, just ordinary cleaning and disinfecting. Those things are already taking place, and decisions are already being made as to an adequate frequency for wiping off break room tables. Just codify that in a document and make sure that there's a system to ensure that it will keep happening. I'm sure around your organization, if the bathrooms quit getting cleaned, you'd hear about it pretty quickly, but just go ahead and put it down in writing in your infectious disease control program. Also in that program, indicate who will monitor for developing trends. You'd have to live under a rock to have not heard about COVID-19 when it started hitting the news back in January and February. So how hard is it to monitor for something this big? Probably not that hard, but you really do have to have somebody in your organization assigned the duty to keep an eye out, watch the CDC website or other public health agency websites to see if something new is emerging. And then if something does emerge, like COVID-19 or Ebola or H1N1 or whatever it may be, go ahead at that point and pull together a team and develop a specific plan to deal with that specific disease and all the protocols associated with it. Next. So the COVID-19 exposure control plan is an example of that specific document that is developed around a specific disease or disorder. Infectious disease control program sits out there in the background, says, hey, when something comes up, develop a specific plan. This is what it looks like. So we have developed plans like this for our clients. They're available. It's got to include all kinds of normal things that you would think about. You've got to train your employees on what is COVID-19. You can't assume that all of your employees are aware of fact versus fiction on COVID-19. There's a lot of wild websites out there that share all kinds of theories about what it is. So you have a duty just to provide the factual information and then inform them what you're doing as an organization to keep them safe during this period of COVID outbreak. What are your protocols? And all of the protocols you're using, social distancing, limiting work shifts, hand washing and sanitizing. But one of the big ones you want to hit on is your flexible work arrangements. And that can take the form of allowing people to work from home if that's feasible, maybe letting them work on different shifts to spread the workforce out if that's feasible, and also flexible attendance policies. And it's really critical when you think about your attendance policies that you create a disincentive for coming to work sick. So if you think about that, you want to have a situation where somebody doesn't want to come to work sick, that they know they'll receive as much pay for staying home sick as they do for coming in, that they'll receive the same opportunity to receive a bonus or any other production based quota bonuses or anything else. That's tough to do because you're essentially paying somebody money to not come to work, but it'll be much better for your organization to keep that COVID positive person out of your workplace where they infect others, and then you deal with that impact as it ripples through your organization. So that's a key factor. We have identified some best practices and incorporated in the plans that we have written. We've picked up on the concept of a COVID-19 supervisor or manager. We pulled that out of the LA area. And really what it means is you're assigning someone in your management system to be responsible for implementation of COVID-19 and having somebody on duty every day to look to see if these systems are working. All these are more or less administrative controls, and we all know that administrative controls are susceptible to creep over time. So you need to have somebody that's going out every day with a checklist and saying, are we social distancing? Are people wearing face coverings? Are they washing their hands? Are we doing what we should be? And if not, making adjustments. Next. So on the training, what is COVID-19? What is your exposure control plan? What is your infectious disease control plan? How do the two relate? Really hit on your attendance policy changes. And then Specifically educate your supervisors on what you're expecting of them. Tell them you've been anointed a COVID-19 supervisor or an alternate COVID-19 supervisor. Bunches of ways to conduct training. You can develop your own training programs, write off your documents, put it together that way. You can use online learning management systems, toolbox talks, putting up informational posters. All these are ways to get the message out. Next. One last topic I wanted to touch on is OSHA record keeping. It has changed a little bit over time throughout the epidemic of COVID-19. Initially, OSHA was taking the position that it could be work-related, and the employer had a duty to consider it OSHA recordable if the conditions were met. So just to refresh everybody, for an illness or injury to be OSHA recordable, there has to be two elements in place. One, it has to be work-related, and two, there has to be medical treatment beyond first aid or lost or restricted time, or one of the other certain conditions have to be met. But they both have to be present. You can have medical treatment beyond first aid, but if it's not work-related, then it's not a recordable case. You can have work-relatedness, but if medical treatment beyond first aid isn't provided or the other conditions aren't met, you don't have a recordable case. So OSHA's position on this has been, unless you are in a healthcare field, they will not enforce against any employers who do not do a work-relatedness determination on a COVID-19 positive person who has received medical treatment beyond first aid, so on and so on. So let's assume that you have someone COVID-19 positive in your organization. They have either received medical treatment beyond first aid, they've had lost or restricted time, which is almost a guarantee because you more or less isolated them from your organization. You do not have to go down the pathway of trying to determine work-relatedness to say, did it happen in the community, did it happen here? Unless you have some specific criteria met, such as you've got an outbreak in your area and all the coworkers, they all worked in close proximity. But by and large, just having a person that's COVID positive in your organization does not immediately force you into a situation where you're trying to figure out work-relatedness. Next. Just wanted to give you a list of some of the resources that we've relied on as we've gone through this. These are all trusted governmental websites. You can go to them for the latest information. I make it a habit to check on a periodic basis to see what's going on, and certainly look to your state and local public health agencies as well. I didn't want to put a bunch up there because some of them are only applicable in certain areas, but I've seen some good state and regional websites as well. And one last thought on that idea is, when you're doing your infectious disease control program and your COVID-19 exposure control plan, keep in mind, if you get a plan from someone, an organization, somebody like Optimum Safety, the plan is written to work everywhere in the United States, but as you implement it, you always have to take into consideration the areas in which you're doing business and whether or not there's any more specific guidance from a state, regional, even city level that drives additional behaviors, and you've got to integrate that into your plan. With that, I'll turn it back over to Steve.
Brian, thanks. We really appreciate the information you've shared here, and Dr. Koehler as well. We've got a lot of good questions coming in. I do want to remind everybody that the question interface is available to you. You've got access right now to Dr. Koehler for the questions that have probably been in your mind as you've been listening to the different news media and watching the daily briefings with Dr. Fauci and so on. As those questions come up, please drop them into the interface. We'd love to get you an answer for them. If they're on your mind, they're probably on somebody else's as well. I do want to just address an issue that we keep hearing about here at Optimum and from our clients, and I'm sure that this is something that's very relevant to your workplace as well. We have a partner referral source with Emergent Safety Supply. They're a national supplier of safety equipment and personal protective equipment. We don't we don't get a cut of anything that's sold by mentioning their name. We just have a mutual referral relationship with them for many years. Good folks. But I asked them about some supply chain issues. You know, what should people expect? And they talked obviously about increased lead times, frequent changes in product pricing from the manufacturer. You're probably experiencing some price fluctuations, increased freight charges right now. Those are changing daily. And then substitution is highly likely as well. They're finding the need to substitute products of equal type to make sure that their clients are continuing their supply that's necessary. We have heard from them to exercise caution when evaluating products or when evaluating purchases of large quantities. So we know that several of the organizations on the webinar today are international in scope, fully North American or maybe overseas as well. You garner a large need for things like N95 masks and so on, and you may be looking to negotiate large deals with suppliers. We do understand that the Department of Justice has been investigating several organizations who have told people that they have available large supply, and then after taking deposits and so on, or payment up front, it's been found out that they've been scamming, and actually the supply never existed. So please be careful when purchasing these types of items in high quantities where lots of dollars are involved. Anytime there's a crisis like this, there are opportunists that come out of the woodwork. So just buyer beware. So what you're hearing from a next step standpoint is it's wise to implement these elements. You've got a infectious disease control program that's been discussed, a COVID-19 exposure control plan. The infectious disease control program would leave you ready for COVID-20 or God forbid, right? But whatever the next outbreak is, you'll have a plan in place. And then the employee training is critical. There's a lot of people that are panicking because of misinformation. As you're bringing people back into work, you want to make sure that they are stable and a good understanding based on sound fact. And then obviously obtaining the necessary PPE and cleaning supplies, establishing your response and reporting plan, and monitoring the updates, as Brian mentioned. Now, we here at Optimum publish many webinars, and many of you have been on our prior MSCI webinars. We focus highly on making sure we deliver good content that has a tremendous value to those that are listening, and that we stay away from any sort of anything that could be looked upon as a sales pitch. And we're doing that again today. However, we know that there is a need, and we know that people are really struggling with this. So we do want to let you know that we do have an infectious disease control program, a customizable COVID-19 exposure control plan, and then we have online training modules for both employees and supervisors, and a regimen of toolbox talks for ongoing training. That information is all available at this link. Please note that this link is case sensitive. So when you're typing that into the address bar in your browser, you want to make sure that you get that link in there, case sensitive. And it will redirect you to a page on our website where you can download some direct information about the webinar today, but also request information where one of our account executives can reach out to you and discuss how we can help you through this. Again, not trying to oversell here, just want to make sure that you know that there are tools available. Everybody that's utilizing these is telling us that they are really helping them to shortcut the time frame and the effort within their organization. I know here at Optimum, we've invested literally tens of thousands of dollars in the development of these resources, and there's no need for you to have to do the same. I think the last time that we looked, we were up over $40,000 worth of billing time for us to build these tools, and it's an extensive project to build them. So with all that said, we're going to move right to Q&A. And again, I really appreciate our panelists today and lending their expertise. We're coming right into the Q&A time with about 20 minutes here. And I'm going to take them in the order that they were delivered to us. Dr. Koehler, I'm going to direct this question towards you. We have a participant who's asking, is wearing a single layer cloth face covering at all effective in reducing the spreading of COVID-19?
Good question. Okay, so anything is better than nothing. So I'll start there. So people are making their own out of cloth, old t-shirts. Some are even studying up on what fiber to put in the layers between the cloth. So the answer is that anything is better than nothing, because if you blast out microscopic particles that have virus on them, the more fibers or obstruction, physical obstruction you put in the way of that movement is beneficial. So if someone's wearing it and they're talking, it's blocking that coming out of their mouth. And then the person they're talking to, who is 6 feet away, who has a mask on, how would those particles get through two masks? So, or two barriers, however you want to call it. So while it certainly doesn't meet N95.03 microns barrier level, it certainly is absolutely better than nothing. And anybody who says cloth masks are stupid is themselves uninformed.
Very good. I appreciate your response. So what I'm hearing is that it's better than nothing. However, I do know also that CDC has issued a pamphlet on mask designs and how to build your own. And we've actually been using that here at Optimum for guidance for our clients and to inform our plans of the types of masks that are best to use. So that's another resource at cdc.gov. And on that website, on their COVID-19 page, there is a nice clean discussion on this topic as well. So thank you for that. Dr. Koehler, while we have you, I'm going to ask the next question your direction as well. How effective are disposable thermometers for workers to self-report their temperature in an active worker monitoring program?
Okay, so my question would be, who's going to buy the machines? Or are they just going to use a mercury thermometer? So
I don't have that detail on the question.
yeah, so I would say if you can figure out where they can get them and have them, if you want to buy some sort of temperature monitoring device for your staff and provide that to them to keep at home and say, if you have a fever, don't come into work that day, that's fine. There's expense involved, and the dog's going to eat the device and you'll have to get another one for people, but so that's an interesting question. I've heard of companies that check them on entry. I know that there's places I've gone where they check temperature on entry by an infrared device that captures your temperature off your forehead without touching you. So you could either do it at the factory level or you could have them do it at home, but doing it at home is dubious, in my opinion, relative to a lot of different factors. Proper usage, they lose it, they don't do it, they forgot, they don't care. I mean, folks want their paychecks, and they have a little fever, they might say, forget this, I'm going, I have my mask on, or something like that.
Very good. So your question is more towards the actual viability of the solution, not necessarily the effectiveness. It sounds like, though, in the term disposable thermometer, you would find those to be as effective as an infrared or mercury thermometer, that type of thing.
Maybe. I've never heard of such a thing, actually.
Okay. Yeah, I'm not familiar with that term.
It's probably something like, because I know on the drug testing cups, they have a temperature strip on the drug testing cup, so the urine causes a temperature change. The urine temperature causes a temperature change on the strip, which gives it a color which you read for compliance on temperature on a urine collection. So I'm sure it would be something, maybe hold this between your fingers for 30 seconds, and if the color is yellow, it's bad. If it's blue, it's good. You know, a color metric type concept, better than nothing. So I mean, hey, if that's available and you can buy large quantities and pass it out, and they use it, I can't be against it.
Sure. Okay. All right. Very good. Okay. Well, thank you. Brian, let's give Dr. Koehler a rest here, and we'll have a policy question for you. We have somebody asking, with different states having variable levels of infection rate, do we need a one-size-fits-all policy?
Sure, I can handle that. It's our recommendation when you have organizations that are across multiple states or even regional, county level jurisdictions, you run with one major plan, and then at a corporate or organizational level, but you also allow flexibility for customization on a facility by facility basis to bring in those additional requirements that are necessary for one county or other. You see a lot of differences in California right now, county by county. So there's no way that one plan for an organization with multiple locations in multiple California counties is going to be successful using that plan unchanged in all locations. So have one plan and then customize as necessary at the local level.
Yeah, that's great. Yeah, what fits in Orange County or LA County isn't necessary in the middle of Nebraska, right? And we're seeing rates now by county that are showing very low infection rates, even here in DuPage County, Illinois, compared to Cook County. So the further we get out of the large population centers, it seems that things are changing. So, okay, good. Dr. Koehler, do you have anything else that you would add to that?
No, that's okay.
Okay. All right, great. So I do want to remind our participants that we've got a fair amount of time here for Q&A. We've got several questions in the queue, and I'll continue working through those, but it looks like we are going to have time to take some more. So if you have other questions, please continue to submit those, and we'll do everything we can to get them answered for you. Okay, let's go to Dr. Koehler on this one. The question is, if one is using and in quotes, fiber mask, so I'm not quite sure, I'll let you interpret that how you'd like, not N95 quality, can you spray with Lysol periodically, even daily, for continued use?
That's a fascinating question. I mean, yes, you could. It would kill what was on the mask, and I wouldn't be against that. I think the consideration, though, you have to be careful of is what are the implications of inhalation of Lysol. So you could create a pulmonary problem, or you could create an irritant that could become workers' comp if they claim a Lysol pneumonitis or something. Obviously, Lysol kills bacteria and viruses. It could create you'd want to look at the label on Lysol. I haven't looked at it lately, and the MSDS sheet or what have you, and see if it's an irritant. I suspect that this would have come up, and I haven't heard of this, but it probably would have come up if that was a feasible concept. But there are people reusing PPE. They're using it all day and letting it sit. I'll mention this, though, that you can sterilize in 1 hour in direct sunlight. So if someone has 2 masks, they can alternate days and leave it out in the sun, hoping it's not going to rain, or have someone to get it if it starts raining. But 1 hour in direct sunlight kills COVID-19. So that is something I tell people, that they can alternate masks on a given day. So that might be a better solution than spraying Lysol on the mask.
Very good. Okay, good. And I believe, so here at Optimum, we've gotten some disposable surgical masks. Early on, we were able to get some supply of those before we received our cotton reusable or washable masks. And but those are considered disposable. So at the point where you've worn them for a day or for a shift, or in and out of in our case, in and out of the vehicle and interacting with people on either a construction site or inside of an industrial facility, we would then dispose of those masks. We wouldn't try to reuse them. There's a reason they're called disposable. And then the cloth masks that we have are machine washable. So the presumption is that those could be laundered or hand washed even with a good laundry soap, antibacterial, and reused again once dried, correct? Dr. Koehler, you may be muted. So is that a correct use of a reusable versus a disposable mask?
Yeah, the machine washing will kill the virus.
Okay, very good.
20 seconds of hand washing kills the virus too. 20 seconds of hand washing for your hands. So machine washing of a cloth mask absolutely would sterilize it from COVID-19.
Okay, and so it can be laundered in regular laundry soap. It doesn't need to be anything special other than that.
Correct. Same
Okay,
is true for soap.
Very good. Thank you. Appreciate that. And we're going to just stay with the mask topic for a minute. So this again to Dr. Koehler. So once COVID is stopped, then masks will not be necessary? Or is this a suggestion that going forward, we should use a mask always?
Another really good question. So we don't know the future on this. I'm suspecting the mask will be no longer necessary after a period of time. I think there'll also be a herd phenomenon develop where people are going to say, forget it. We're way down. There's hardly any case. I'm not wearing this stupid thing anymore. So you're going to have people that will literally refuse to wear it. So it will go away over time. Next winter is going to be a really big testing, starting in November, December. What's going to happen in the winter? Are we going to get a rebound here? And if so, we might have to go back to masks. So I really can't predict what's going to happen with this disease. Nobody can. This thing is diabolical. We've never seen anything like this in the history of mankind. So at least this particular virus, obviously the flu pandemic of 1918, it was influenza, not COVID. It wasn't a coronavirus, it's an influenza virus. But obviously we've had pandemics, so now we have one per century, and so we don't know what this thing's going to turn into, and we don't even know where it came from, but that's a whole nother story.
Okay, very good. Very good. Well, thank you for that. I'll put this question out there. I know, Brian, that you have done some research on this topic, and I don't know if enough to be able to answer this question effectively. So feel free to ask Dr. Koehler to take this. The question is, we have been informed of sprays that can be used to treat a surface so that it kills COVID, sprays like Microban Protect or ionic copper. Can you just have a discussion of what you understand to be the right types of sprays or disinfectants to be used to treat a surface or kill the virus?
Yes, absolutely. What I would direct the question asker to is, if you've got a particular product in mind, go to the CDC website on COVID-19, and you'll see in their directions for disinfecting, and they keep making reference to EPA-approved disinfectants. And there's a key difference. Cleaning is removing soiling, dirt, food particles, things like that. Disinfecting is killing whatever's on that surface, whether it be viral, microbial, whatever it could be. But take a look on that. You'll find a link that takes you out to EPA approved disinfectants, and then you can look to see how to know whether or not the particular product you are looking at, whether it meets the EPA guidance and therefore the CDC guidance. I don't know those two products off the top of my head, but that's the way I would look at it for any product that I was considering using.
Excellent. Yeah, I'm sure. Well, we've been seeing here flyer after flyer coming in from different suppliers, some that we do business with already and some that are trying to promote their product. And there are a lot of products out there that are being shown to be beneficial. So it's good to have an agency like that to measure them against. Dr. Koehler, I've got one here for you about antibody testing. The question is, what is the benefit of employers conducting antibody testing other than letting employees know? And the follow-up question is, aren't they still able to get the virus again?
Good question. Nobody knows the answer to this yet. We don't have any data on relapses. We know that there were 74 alleged relapse cases in South Korea, where the folks had COVID-19 proven positive tests. A number of weeks later, contracted COVID again. None of them had a disease that was worse than the first episode. That's good news, but they got it again. And so was that a relapse of latent viruses in their system, or was that a whole new infection? I suspect my theory would be that those 74 individuals had an inoculation level that was really high, which overcame their antibodies that they had in place. So I believe that was a second infection from a high inoculation, because once you beat the virus, you beat the virus. It can't self-regenerate. It's not like tuberculosis that can be dormant and latent in your system for many years, because the virus does not have its own self-sustaining apparatus inside of it. It's lacking everything that it needs other than RNA that diabolically co-opts the machinery of the cell that it attacks. So antibodies confer that you had the infection, that you did fight it off, and you do have some level of protection. So if you do it as a company, it's a benefit. It would be a benefit to the worker to know, hey, I have antibodies. I'm quote unquote relatively immune, maybe immune or relatively immune. I have a defense. That's good news. And you should feel very comfortable that anybody who doesn't. So it's always good news if they have positive antibodies. So you can do it, but there's cost involved and logistics about, who's going to draw their blood, where's it going to be done at, that type of thing.
Okay, very good. Excellent. Well, we've got time for one more question. I'm gonna take this one really quickly. Just ask you to give us a little bit of an idea. On the call, we have a lot of MSCI members, and like me, we love the MSCI conferences and all gathering together in large groups and networking and getting to know one another again and meeting new folks. And the question that's come up is, when do you expect big gatherings like large conferences to be able to be had again? Do you have some thoughts on that you could share?
If that's for me.
Yes.
Large gatherings, Illinois, I have no idea. Governor Pritzker has been very aggressive to limit return to normal activities. So there's been projections that, the 5-stage return to do, this fall, maybe for large gatherings, maybe this fall, maybe not until we have a vaccine. It's actually stage 5 was vaccine availability. So that's unknown. It's absolutely unknown at this point.
Okay, very good. Well, I appreciate you answering that as candidly as you could. We're all waiting for some return to normalcy, whatever that might look like. So very good. At that note, we're going to go ahead and close the Q&A. We're right at 12. And I want to thank you for joining today's webinar. Just want to remind everybody of the link here at bit.ly/ all caps MSCI-COVID, and you'll find this page with the resources for you. In addition, as always with MSCI, we have the Optimum Safety Helpline, and we are wide open to helping with any questions we can answer between the hours of 9 and 4. You can submit those questions by email at the address here. This information is all in your handouts. Again, I want to thank our panelists today, Dr. Koehler and Brian Dudgeon from Optimum, for your wisdom and sharing that with the audience today. And at this note, Chris, I'm going to turn it back over to you to close us out.
Okay, well, thank you, Steve and John and Brian. We really appreciate all that information. So for everybody who is on the webinar, you will receive the slides in a handout. So you'll get that link later today in an email. It'll come from MSCI. And within 24 hours, you're also going to receive another email that's going to have a link in it to our post-webinar survey. We ask that you complete that survey because we rely on your feedback to help make these webinars better. Anything you can offer us in the way of improvement is perfectly within your right, and we really want to do those things so that you'll come back over and over again. This webinar has been one in an ongoing series of weekly webinars that MSCI has been presenting, and almost all of them feature some relevant aspect of managing your business better during the COVID-19 pandemic. So we appreciate your attending all of these. And in fact, on another note, please join us next Tuesday, that's May 19th at 11 a.m. once again, for another webinar. This one's going to be a safety fireside chat that features Brad Bullard from Coil Plus, another MSCI member, and Steve Yates and Brian again. This is a free-ranging discussion on critical issues surrounding health and safety during this pandemic. Another opportunity to listen to an MSCI member who's been dealing with this, like you all have, and to ask questions about best practices and things like that. So, that being said, on behalf of MSCI, Optimum Safety, Dr. Koehler, and especially all of you who've been listening, thank you for attending. Have a safe rest of your day, and please stay well, everyone. Thank you.